Hello and welcome. My name is Faizan Arshad. This is episode number 17 of the EMSNation podcast. We are starting off this bright and sunny Monday morning. It may or may not be sunny where you are. I do not hypothesize I know that information. Nevertheless, it is EMS week here in the United States of America, a time that is exciting for providers and the hospitals that they interface with, and certainly an opportunity for us to focus, reflect on the quality of care that we provide in the pre-hospital space and ways we can improve not only that care, but also our own healthcare, well-being, and resilience in dealing with the daily challenges that we do on a day-to-day basis. Today's episode is focused on intrathoracic pressure regulation, a new modality to help understand the physiology of CPR. And we are very excited and lucky to have Dr. Keith Lurie on the call for us. This one is a long one, which I am unapologetic about. Dr. Lurie beautifully illustrates the physiology of cardiac arrest in a way that helps bring this to light, and also focuses on the systems of care that are involved in optimizing outcomes for pre-hospital sudden cardiac arrest. Dr. Keith Lurie is a practicing cardiac electrophysiologist and resuscitationist scientist who over the past 25 years has devoted himself to study novel ways to resuscitate patients experiencing sudden cardiac arrest. He earned his bachelor's degree at Yale University and his medical degree at Stanford. He studied cardiovascular medicine at UCSF and later joined the faculty there. He's been on the faculty of University of Minnesota since 1991. As one of the leading innovators in the field, he has helped to develop new devices and methods that optimize cardio-pulmonary resuscitation and in turn improve survival chances following cardiac arrest. In addition, he has become a respected thought leader in developing and implementing a systems-based approach to managing and treating sudden cardiac death events. Some of his most notable contributions include the development and assessment of various resuscitative techniques such as the impedance threshold device, the ITD, active compression-decompression CPR, and the use of intrathoracic pressure regulation to modulate cerebral and systemic circulation in states of severe hypotension and head injury. A professor of emergency medicine and internal medicine at the University of Minnesota, Dr. Lurie also directs an NIH-funded research laboratory at Hennepin County Medical Center in Minneapolis and is a consultant for Zoll Medical. So hang on, this is a great one with Dr. Keith Lurie, and we certainly encourage you to save this one to your podcast list so you can listen to it again and really dive in and understand the physiology of CPR. So we're very excited to have Dr. Keith Lurie on the line, and he is joining us just as he wakes up in the Pacific Northwest, early 6 a.m., to talk all about intrathoracic pressure regulation, the ITD impedance threshold device, as well as active compression-decompression. Welcome to the show, Dr. Lurie.
Good morning, and thank you so much for having me.
We're very excited, and we are focusing on intrathoracic pressure regulation as well as the overall concept of developing a chain of survival in pre-hospital cardiac arrest to improve outcomes, and also how these are internally linked and tied together to really deliver the best outcomes and performance for our patients across the United States of America.
Great.
I wanted to start by rewinding back in time to 1987 when you were practicing and you had a very interesting patient scenario and encounter. Could you tell us a little bit more about that?
I started my cardiology fellowship back in 1986 at the University of California in San Francisco. And at the time, I was also a research biochemist. I had set up a laboratory there and was working on the biochemistry of the heart and simultaneously becoming a cardiologist. And about a year and a half later, I was asked to attend one morning at the San Francisco General Hospital this was a Sunday morning, and one of the attendings asked me just to take the weekend, and I said, sure. And I walked in to rounds on Sunday morning, and I met the intern and resident who told me that there was a remarkable case that they wanted to share with me, and then they started to laugh. And that had my curiosity piqued. And then they explained to me that a man had come in the night before who had had a cardiac arrest, and family members did not know how to do CPR, but they had successfully resuscitated him with a common household plunger. So the son had grabbed the plunger, and he and his mom plunged Dad's chest, and there he was sitting in the CCU bed, awake and alert. And if this wasn't funny enough, the fact of the matter is that they had done this a week before and then a month before that. So this was the third time they had plunged Dad's chest. So I walked in to see the gentleman who, at the time we called patients like this man medically indigent adults. So they didn't have health insurance. He had come from Iran. And there he was, awake and alert. And it was clear that he needed something definitive done to fix his heart, and it turns out he did have an angioplasty on that admission. But the 22-year-old son looked at us and said, Doc, you should have a plunger at the end of every CCU bed. So after we finished seeing the patients in the CCU, we did what we usually did, which was go back and huddle and talk about the cases. And this case was very funny, but it also is very intriguing. And ultimately, together with the intern and resident, we wrote a little letter that was published in the Journal of the American Medical Association that we entitled CPR, the P stands for Plumber's Helper. And while the initial letter was rejected from the New England Journal of Medicine, a couple of years later I dusted it off and I discovered it again on my desk and sent it into JAMA with the two co-authors, and it was immediately accepted. And they called me from Good Morning America in October of 1990 and asked if I would go on the air talking about resuscitating someone with a plunger, and I said, no, I don't think we can do that. But that didn't stop all the major news networks from showing up at the cardiology office the following day. And it was on that day that I knew that my academic career at the University of California was over. But what intrigued us, and the reason that we wrote the letter, is because in San Francisco in the late 80s, HIV infection was in full bloom. It was a relatively violent city in some parts, and nobody really wanted to do mouth-to-mouth. And we thought if we plunged the chest, we could turn the chest into an active bellows. Pushing down on the chest would push blood out of the heart to the brain, and when we pulled up, we'd suck more air into the lungs, and we thought we could potentially avoid having to do mouth-to-mouth. And the story went around the world. We made it to the first night of the Jay Leno show, why do cardiologists and plumbers have the same salary? And AMBU picked up the story, and we spoke with them, and ultimately they worked with the University of California to develop a product. And that product also introduced me to the world of inventing, as we had submitted a disclosure to the University of California about this concept. So that was, for me, a big change in my career. I didn't expect to be studying changes in intrathoracic pressure and the regulation of those changes for the next 25 plus years. But in fact, that has happened as the plunger patient, so-called index case, opened up a whole new way for us to think about moving air in and out of the lungs, moving blood in and out of the heart, removing venous blood from the brain so that we could lower intracranial pressure and further enhance circulation of the brain. And it's led to new treatments for patients in cardiac arrest, new treatments for patients in shock from blood loss, orthostatic hypotension, and actually it also helps patients with low blood pressure. The concept helps patients with low blood pressure from multiple causes, including sepsis, trauma. And we're working on new technologies now to help patients who have brain injury and increase intracranial pressure, because we discovered that if we create a vacuum inside the thorax, similar to the concept of the plunger, that we can reduce venous blood from the brain and hence lower intracranial pressure and improve, at least in pigs, outcomes, and in humans, lower intracranial pressure. So the plunger patient opened our eyes to the possibilities of enhanced regulation of intrathoracic pressure to improve circulation. And many years later, it became very clear that the plunger patient helped us to better understand the fundamental physiology and mechanisms of breathing. And in fact, when we take a very deep breath in and sigh, we not only bring air into our lungs, but we also bring blood back to our heart. We suck venous blood out of the brain so that our brain gets better perfusion. And this is part of our normal physiology. So for anybody who's listening who's a runner, at the end of your run, if you go for a fast run and you're panting, that panting is doing some amazing things to your physiology, enhancing respiration, enhancing circulation, enhancing blood flow to the brain, altering your sympathetic and parasympathetic nervous system, all by taking a deep breath in. And so we've been harnessing that physiology, and the index case was the start of all of it.
That is an absolutely fascinating story, and it's remarkable how a single patient can not only transform an entire career trajectory, but here we are in 2016 with randomized, placebo-controlled, prospective, pre-hospital clinical trials with these devices, which is absolutely remarkable and very exciting. Now, before we launch into the physiology of intrathoracic pressure regulation, and that really is the goal for folks listening to help understand this concept and bring that physiology of CPR to light. I was wondering, with the index case, and I'm not sure if this is lore or not, but the first iteration of the device was to focus on the active compression-decompression to generate the negative intrathoracic pressure, if I'm not mistaken, and the impedance threshold device came later. Is that correct?
That's correct.
So in this particular patient, are you able to hypothesize why the active compression-decompression may have worked without the impedance threshold device? In other words, the negative intrathoracic pressure generated with the ACD would essentially dissipate without the ITD. Is that correct?
That's correct. But like everything else in science and in medicine, this is sort of an incremental process. So what you're alluding to is that when you pull up on the chest, air rushes into the lungs, and so the vacuum that's created inside the chest is reduced or completely eliminated by the air rushing into the lungs. So you have a pump, but the pump or the bellows, which harnesses the chest movement, really primarily affected ventilation and not circulation. But if one measures pressures inside the chest, as we have done quite extensively in animals and in humans, the definition of intrathoracic pressure varies depending on who you speak with. If you measure it in the airway, you get one pressure during the decompression phase if you pull up the suction cup. If you measure it in a distal airway or in the esophagus, so you have an esophageal manometer to measure intrathoracic pressure, you may get another pressure, but typically it's about the same as the airway. But if you measure intrathoracic pressure with a pressure transducer in the so-called pleural space or intrapleural space between the lung and the pleura, then when you pull up with a suction cup device, you actually create a measurable vacuum. So you have a vacuum that is immediately dissipated by air rushing into the lungs when you pull up with a suction cup. And by the way, you see the same thing with normal chest wall recoil. There's a little vacuum that develops, and that's further enhanced by pulling up with a suction cup device. But the vacuum that we do see is a so-called intrapleural space vacuum. And that's not unlike the kind of vacuum you might see when you use an iron lung, because the concept is conceptually similar to an iron lung. So if you put somebody inside an iron lung and create a vacuum outside the body, then the lung gets filled. There's no real vacuum inside the lung itself, but there is a vacuum that's created between the skin, the muscle, the bones, and the pleural space that's enhanced. So the actively pulling up on the chest alone helps some, but because it doesn't help enough, we were challenged by the physiology, which led ultimately to the discovery of the impedance threshold device concept.
Very important for folks to understand that. And just to back it up and simplify it and make sure we're all on the same page. So for a normal adult who's breathing spontaneously, during inhalation, the diaphragm moves down, the chest wall moves out, which creates a negative pressure vacuum that draws air into the lungs and blood into the chest and slightly lowers ICP because of venous return. And during exhalation, the diaphragm moves up and the chest wall moves in, which creates a positive pressure that forces air out of the lung and diminishes blood return to the chest and slightly raises ICP. Is that correct?
That's absolutely correct. And the important concept that I like to think about and talk about is that when we breathe, for many years we focused on the movement of air, oxygen, CO2, coming in and leaving the lungs. But it turns out that our breathing also is directly linked to circulation of blood. And when we take a deep breath in particular, we not only draw air into our lungs, but that vacuum that's created in the thorax, especially with a deep breath or a sigh, is associated with significant movement of blood back into the right heart and a significant decrease in intracranial pressure due to the fact that venous blood is being sucked out of the brain back into the right heart. And then, as you stated, when you exhale, you actually increase the pressure in the chest. And depending on whether the airway is open or not, you can enhance circulation. But it's that inspiratory phase that's so important. So when we think about somebody who's taking their last breath, typically we think the last breath is associated with the last gasp to suck more air into the lungs. But that's really only a little bit of the story. The last gasp is actually associated with trying to get more circulation to the brain. The last gasp sucks more blood back into the heart, lowers intracranial pressure. So whatever the diastolic pressure is at the time is typically enough to provide some additional perfusion to the brain. So when somebody is gasping during CPR, it's not because they're just trying to physiologically enhance the amount of oxygen in their body and their brain, but they're actually using that as a pump to enhance circulation, especially for the brain. So the physiology is beautiful. When you gasp, the resistance in the brain to the brain flow goes down because the ICP goes down because venous blood is pulled back into the heart, and that venous blood helps to enhance preload. And so during the relaxation phase, in fact, diastolic pressure goes up a little bit, and you have an enhanced gradient from the left heart and the left side of the circulatory system across the brain. So the last gasp is not just about oxygenation, it's about circulation and improving blood flow and the physiology of the brain. And that's what we have discovered over time, and we've been trying to harness with our devices.
Fascinating. So to dig into the physiology of CPR more, what exactly is happening during the recoil phase of high-quality CPR and chest compressions, and then how does the technology harness the vacuum generated during the recoil phase to increase preload?
So when we perform CPR with high-quality CPR and we push down on the chest, we increase the pressure inside the thorax in general, and that pushes air out of the lungs, and that pushes blood forward, and most of it goes to the brain. So at the end of the compression phase, the heart chambers, especially the left and right ventricle, are relatively empty, and the air in the lungs has been pushed out as much as possible. So in order to refill the heart, we allow the chest to recoil. And if we have full chest wall recoil, then a little bit of a vacuum is created by the ribs and the chest structure moving upward rapidly. And that upward motion creates enough of a vacuum to pull a little bit of blood back into the right heart. And it also pulls some blood from the lungs, which is really a reservoir for blood, into the left heart. So during the recoil phase, we refill the right and left heart. And as the blood is pulled back into the thorax by this little vacuum that's generated inside the thorax, then blood comes from the outside the thorax, in particular the brain, but also the abdomen, extremities, etc. So you pull a little bit of blood, venous blood, out of the brain, which allows blood to move forward if the arterial pressure in the brain is a little bit higher, just due to the resting difference in compliance between the arteries and the veins. So in other words, the decompression phase, when the chest is just allowed to recoil, generates a small vacuum, and that vacuum triggers a number of different physiologic events. One, more blood is returned to the heart from outside the thorax, so you increase so-called preload on the right side. Two, blood moves from the lungs into the left heart, increasing the volume and refilling the left heart, so when you push down again, you have some blood to push out to the brain. Three, intracranial pressure is reduced because venous blood is pulled out of the brain and back into the right heart. And taken together, you have a not very efficient pumping system between the compression and decompression phase, but efficient enough to sometimes bridge people between cardiac arrest and full resuscitation.
And you write about that quite eloquently in the review paper, The Physiology of Cardio-Pulmonary Resuscitation, and we will link that up in the show notes for 2015 in the Journal of Anesthesia and Analgesia. So the limitations of standard CPR. So while it may be effective, that's what's happening physiologically, but there are ways to augment our cardiac arrest resuscitation to improve outcomes. Now, a quick question regarding recoil. As an EMS medical director, it's a little bit more straightforward to teach people the importance of the proper rate of compression, the importance of the proper depth of compression. How do you go about optimizing or teaching people about the importance of recoil? And I know you have two amazing EMS medical directors in Minneapolis who have both implemented high-performance CPR systems. Is there any additional insight to relaying the importance of the concept of recoil to pre-hospital care providers? How do we teach that better?
I think for me, and when we've taught it, the most important message is to try to get individuals who are performing CPR to understand the physiology of the recoil phase. It's pretty easy to think about pushing down, and that increases pressure inside the chest and blood moves out. But for many, many decades, people have forgotten about the importance of the recoil phase. And once you understand the physiology, that the heart has to refill, and that by allowing full chest wall recoil, you actually have some venous blood come out of the brain back to the heart because of that vacuum during the recoil phase, that helps. But what we noticed first in a clinical trial in Milwaukee, in collaboration with Ron Perillo and Tom Afterheide and others, is that firefighters and first responders in particular thought they were doing high-quality CPR, but they were actually leaning on the chest and not allowing the chest to fully recoil. And we discovered this by actually measuring pressures inside the chest, and we noted that the pressure was always positive. So somebody was always basically leaning on the chest, and the chest was not allowed to recoil. And if it's not allowed to recoil, then you never create the vacuum in the thorax. So you can push all day long, but the heart never refills. So CPR becomes less and less and less efficient. And in fact, all of a sudden, each time you push down, you're increasing pressure in the brain, intracranial pressure, inadvertently, not knowingly. And the result is what we see, which is a very high mortality rate. Nearly everybody dies. And when we went back to the pig lab and studied this, and in a very meticulous way, had full chest wall recoil or incomplete chest wall recoil, where pressure was persistently applied to the chest, even during the recoil phase, we saw the worst physiology that we have ever seen in CPR. It's worse than hyperventilation, in fact. So leaning on the chest and not allowing the chest to fully recoil results in very bad physiology. So we try to teach that to people who are doing CPR. And then we also developed a little research tool, we can call it, which is called the Rescue Man Demonstrator. And the Rescue Man Demonstrator is basically a little simulation of the lungs with some balloons, the heart with a balloon, and the chest. And when you push down on the little Rescue Man Demonstrator, you can watch the lungs empty and the heart empty. And when you allow the Rescue Man Demonstrator chest to recoil, a little bit of air comes back into the lungs, and a little bit of blood, as it were, comes back into the heart. And if you continuously push on this little demonstrator and don't allow the chest to recoil, you can see that there's zero circulation, because you basically have clamped the hose going into the heart. There's no blood that's allowed to come back in. So it is indeed a difficult concept to teach, but we try to focus on the physiology and the importance of refilling the heart. And if you're leaning on the chest all the time, the heart doesn't refill, so there's nothing to pump out.
Very well said. I think, as has been eloquently stated in the past, intrathoracic pressure regulation is invisible. And that disconnect from providers is challenging, and helping to understand the physiology really goes a long way to, really internalizing why recoil is so important.
The changes in intrathoracic pressure and the consequences of them are indeed invisible. Nobody really thinks about the fact that when we give a positive pressure breath with a resuscitator bag or ambu bag, that we are affecting circulation in a dramatic way.
Hey friends, I'm going to take a brief moment to pause the show and bring you a word from our sponsors. No, not the sponsors you may traditionally think of, but rather sponsors that are aimed to help eliminate healthcare disparities. This is a very special project I'd like to announce during EMS Week for folks to trial. It comes at absolutely no cost and is ultimately designed to optimize your training experience and help translate into improved outcomes within your community in relation to out-of-hospital cardiac arrest. Recently, a group of colleagues of mine and I had the pleasure of coming together and reviewing the science and literature on feedback in CPR, and the data pretty much speaks for itself. Dr. Bogro, the State EMS Medical Director of Arizona, has done tremendous work on this, and we now know that all the major defibrillator companies come with some sort of active CPR feedback. Nevertheless, we are acutely aware that once you know a single EMS system, you know a single EMS system, and budgetary constraints are real-world problems and challenges. Not everyone can afford the defibrillator component to their device. So what have we done is designed a watch app for the Apple Watch called Perfect CPR. Now, we should be very important to state this is designed for training purposes only, but nevertheless, once a provider opens up the app using the accelerometer and gyrometer built into the Apple Watch, you will be able to get direct feedback on your rate, depth of compression, as well as recoil. So please check this app out. It is available at $0.00 in the Apple Watch iTunes Store, and is called Perfect CPR. Please also find us and follow us on Twitter at Perfect CPR. Again, we're beta testing for this, very excited to launch during EMS Week at a cost of $0.00, and would love your feedback. We can all do a part to help improve the health disparities within our country, and feedback is definitely a requisite component to that. Check us out.
And the other way that we talk about this then is not just the recoil phase, but what happens when you increase or decrease pressures in the chest in general. So when you squeeze a resuscitation bag, the pressure in the chest goes up, intracranial pressure goes up, circulation back to the heart goes down, and yet you need to inflate the lungs. So if you do one of these too often, it's not good. That is hyperventilation. The physiology is not unlike the reverse when you lean on the chest. If you lean on the chest and don't allow the little vacuum to develop during CPR, then you basically cut off blood flow to the heart and the brain. They're all interrelated. Any manipulation of the intrathoracic pressure, whether it's with recoil of the chest or positive pressure breath, has significant, in fact, profound physiologic consequences.
Very interesting. I'm hoping we can use that premise or basis to contrast the theories of the cardiac pump versus the thoracic pump.
Sure. Sort of traditionally, when CPR was first introduced, and then for the next 50 years, people have argued whether or not the reason the blood flows from the heart to the brain with each chest compression is due to the fact that the heart is squeezed between the sternum and the spine, or because the pressure inside the thorax goes up and you don't have to squeeze the heart at all. You simply increase pressure inside the lungs and all of the structures inside the chest, including the heart. And the truth lies somewhere in between. We know that if we do not squeeze the heart, as it were, with the cardiac pump theory, and just increase pressure inside the thorax, we indeed can move a fair amount of blood into and out of the thorax with each compression-decompression phase. But what happens over time is that the ribs either break or the structures in the chest soften up and remodel with continuous chest compression and release. And so ultimately the heart does start to get compressed between the sternum and the spine, and you have two mechanisms of action at least that result in forward blood flow from the heart to the brain. One, the decrease and then increase in absolute changes in intrathoracic pressure, the so-called thoracic pump. And then the second relates to the change in actually squeezing the heart. And the third pump occurs when you block air from coming out of the lungs. So if you push down on the chest and air is not allowed to come out of the lungs, and you further pressurize the thorax, and I like to refer to that as the pulmonary pump. And for people who are in trouble physiologically at times, they'll both inspire through clenched teeth and expire through pursed lips. And so even in the non-cardiac arrest state, people use the pulmonary pump as well. And if you've ever seen somebody who is Kussmaul breathing, especially somebody who has diabetes and has, let's say, diabetic ketoacidosis, where they're panting heavily, all three of those pump mechanisms are, well, at least two are used when the heart itself is pumping. So it's complicated, but the simplest answer is both the thoracic pump and the heart pump, cardiac pump models, I think, are active during different phases of CPR.
Fascinating. And I'll ask another question, which I've asked you before, and that is, as the resuscitation science advances, there is an increase in the use of transesophageal echo in the emergency department and certainly in the ICU. And we're noticing that with age, certainly we have hypertensive changes and displacement of the PMI. The heart oftentimes is not being directly compressed as we visualize through actively transesophageal echo. How do you see the future of compression science advancing as we learn more about these varying physiologic concepts?
Well, indeed, that's correct. If you push on the chest in the location recommended by the American Heart Association, the heart itself is 3 to 4 inches higher than where your palms rest on the chest and a couple inches to the left. So we're clearly, in general, not compressing directly on the heart. So that speaks to the importance of the change in intrathoracic pressure, or the thoracic pump model, as the primary driver for blood flow to the heart and the brain during CPR. There are some who have suggested we should move our hands a little laterally to the left chest and a little higher. I'm not sure we know enough to be able to do that. There are clearly some devices that circumferentially compress the thorax, and this began with vest CPR. And in fact, the thoracic pump model of CPR was first described by the group at Hopkins with a circumferential vest and morphed into the concept that's embedded in the autopulse, at least to increase pressure during the thoracic squeezing, as it were, model. So in the end of the day, my suspicion is we probably don't need to move the position of where our palms are or where devices are during the compression phase very much because of the importance of increasing intrathoracic pressure during the compression phase, which can be accomplished by simply putting your hands or a device on the chest almost anywhere and pushing down. And the downside of moving the hands to the left chest, I think, while it's completely speculative, we may well increase rib fracture rate.
Okay, fair enough. I was hoping now to get into the research. And there are several smaller trials that preceded Rock Pri-Med, but Rock Pri-Med in the New England Journal was the largest and ended up being a neutral study. And I wanted to just tie the conversation of the nuances of this article with a review done by Dr. Yiannopoulos in 2015 in Resuscitation that retrospectively looked at the prospective data and really highlighted the importance of high-quality CPR. So I would love for you to expound on that, if you would.
Sure. So the Resuscitation Outcomes Consortium was an NIH-funded 10-site North American research consortium that for over 5 years, in fact for almost a decade, has studied a number of different questions related to CPR. And the very first one that they asked was, does the impedance threshold device improve neurologically sound outcomes after cardiac arrest? And simultaneously in that same study, they asked the question, does 30 seconds versus 3 minutes of CPR before shock improve outcomes? So they looked at two questions simultaneously in that study. So let me back it up for just a couple minutes to describe the impedance threshold device. We've talked about it, but we haven't talked really about how it was discovered and what it does. So let's go back to the question of the plunger patient and active compression-decompression CPR. When we're plunging the chest and pulling up with a suction cup, or when we're pushing down on the chest and allowing it to recoil on its own passively without the suction cup with just a pair of hands, the little vacuum that we've been talking about for the last 20 minutes or so is enhanced during the recoil phase, but it rapidly disappears as air rushes into the lungs. So we've turned the chest into an active bellows that moves more air or respiratory gases. And we discovered that back in 1993 when we were trying to measure the pressure generated during the recoil phase of CPR as we pulled up on the chest with a suction cup. And we were comparing the suction cup device with active compression-decompression CPR with manual CPR with a pair of hands, and noted that we were moving 4 times as much air. So we had about 16 liters of air moving in and out of the chest with the suction cup device versus about 4 liters of air with a pair of hands. And we also noted when we were evaluating these two methods of CPR that we were never really creating a vacuum inside the chest as measured with a pressure transducer in the esophagus. And I was talking to a colleague of mine trying to understand how we could maximize or optimize this vacuum in the thorax, because at the time, the clinical studies with active compression-decompression CPR alone were at times positive and at times neutral. And it wasn't clear whether use of ACD-CPR, as we call it today, or the device that we use today to perform that is the rescue pump or cardio pump, wasn't clear that use of ACD-CPR was variable, or the results were variable because of training or the physiology. And as we were studying the vacuum that we thought we were trying to create inside the chest, one of my colleagues said to me when I challenged him and said, "Why aren't we seeing a vacuum?" He said, "I have an idea." His colleague, his name is Dr. Sweeney, an anesthesiologist, and we were studying the suction cup device in humans in cardiac arrest. And when I'd push down and pull up with the suction cup device, there was no vacuum in the thorax. And one day, Dr. Sweeney put his thumb over the endotracheal tube, and when I pulled up with the suction cup device, we observed that the intrathoracic pressure plummeted. So rather than go to zero, we had a vacuum inside the chest of about minus 15 millimeters of mercury. And light bulbs went off. We realized that instead of pulling up on the chest and having air rush into the lungs, we pulled up on the chest and blocked the air from rushing into the lungs, that we could create a vacuum that would suck more blood back into the heart. We rapidly went to our animal lab and showed that the combination of active compression-decompression CPR and what we now know as an inspiratory impedance threshold device, or ITD, or rescue pod, that combination resulted in 3 to 4 times more blood flow to the heart and the brain compared to standard manual compressions. So that was pretty exciting, and that was back in 1994. But at the time, we couldn't find anybody to really drive that device combination forward in terms of a company. And the University of Minnesota didn't want to do it. And ultimately, the FDA didn't allow AMBU to pursue the active compression-decompression CPR alone in the United States. The FDA turned down their application. And so we were left with a device combination that seemed to provide normal blood flow to the brain and 70% of normal blood flow to the heart in animals, and yet we couldn't test it in humans. So we made the decision to assess whether or not the concept of transiently impeding airflow back into the lungs with the ITD, or impedance threshold device, with just conventional standard CPR would work. And again, we started in animals, and collaborators in Europe, completely independent of us, found the same thing. We could double blood flow to the heart by simply, with a combination of high-quality CPR and the ITD, perform CPR. And we were doing these animal studies with a sham versus active device. And we also improved blood flow to the brain. The animal studies further showed that neurologically sound survival was strikingly higher with the ITD compared to a sham ITD with conventional standard CPR. So the FDA and the National Institute of Health allowed us to study this device, the ITD, which you know is the rescue pod, in patients in cardiac arrest in Milwaukee, Wisconsin. And we measured blood pressure, intrathoracic pressure, end-tidal CO2, return of spontaneous circulation, and survival to hospital discharge in 2 studies. The hemodynamic study showed a striking improvement in blood pressure. Systolic blood pressures were doubled, but it was also in that study that we discovered patients were getting hyperventilated on average of 37 times a minute. It was also in that study that we discovered that people were leaning on the chest and not allowing the chest to fully recoil. And we took those observations back to the animal lab and demonstrated that hyperventilation was deadly and incomplete chest wall recoil was deadly. So we began to focus on the issue of high-quality CPR. And ultimately, the NIH performed with the ROC study group a large clinical trial looking at sham versus active ITD alone, since ACD CPR at the time was not allowed in the United States. And after enrolling about 8,700 patients, they stopped the study for futility. They found no benefit or harm of the active versus sham ITD, and they found no benefit or harm associated with 30 seconds versus 3 minutes of CPR before shock. And that study was, at that time, devastating for us. How could it be that in animals we could see improved blood flow to the heart and the brain, improved neurologic function, in clinical trials show improved blood pressure, and then see no benefit at all? In retrospect, 5+ years later, that study is probably one of the most important studies that's been performed in the resuscitation space ever.
Absolutely.
And I say that now because the investigators and others who are not primarily involved in that study were able to peel back the layers of the onion and discover that during the Rock Prime study, many patients did not get high-quality CPR. The compression rate was either frequently too fast or sometimes too slow, but only 50% or less of the patients received chest compressions somewhere between 80 and 120 per minute. And if you had chest compressions that were too fast, it was associated with a significant increase in mortality. More people died. The same thing was true if you didn't have a fast enough heart rate. So if the compression rates were less than 80, it was bad. And then moreover, it was secondarily shown that if the compression depth was not adequate, if it was too shallow or too deep, that also significantly affected outcomes. And only about a third of the patients to a half got chest compressions at their correct depth, which was part of the study protocol of 5 centimeters or about 2 inches. Those same Rock investigators went on to show that if you did chest compressions at the right rate and the right depth, that affected outcomes. And if you added the ITD on top of that, the ITD would work or not work, depending upon whether or not you performed high-quality CPR. So then Dr. Yiannopoulos and some of the Rock investigators more thoroughly evaluated whether or not the impedance threshold device, or ITD, would work in the setting of high-quality CPR. And they found that it worked very well. In fact, in some patient categories, like witnessed arrest, nearly doubled survival to hospital discharge with favorable neurologic function if you have high-quality CPR, defined as chest compression rate 80 to 120 and chest compression depth of about it was 4 to 6 centimeters was the window that they used, which was what's recommended by the AAHA. And they also looked at the whole question of chest compression fraction. You had to have chest compressions at least half of the time. And in that setting, the study was remarkably positive. That simple little airway regulatory device could double neurologically sound survival in patients with a witnessed arrest. And in patients without a witnessed arrest, it was about a 50% relative improvement compared to the controls. And if you didn't have high-quality CPR, then you couldn't affect outcomes in a positive way with the ITD. And more recently, Yiannopoulos and colleagues from Japan have shown that you can actually identify the sweet spot for CPR using the Rock Prime study. Mm-hmm. So that we now know quite definitively the correct rate and depth to have the best outcome. And it's about 105 to 110 compressions per minute with a depth of about 4.5 to 5 centimeters. So that study provided a tremendous amount of information, which was not necessarily described in the first publication in the New England Journal of Medicine, but subsequent analysis really got at what I like to say the truth of the matter.
That's absolutely fascinating, and there's a lot that I'd like to dig into there. But first, you described your eureka moment story with Dr. Sweeney in 1994. What prompted him to put his thumb on top of the endotracheal tube?
So in 1994, it was actually 1993-94 timeframe, at the University of Minnesota, where I practiced at the time as a cardiac electrophysiologist, we had the opportunity to place the first implantable defibrillators that use transvenous leads, which is the standard of care today. But before that point in time, if somebody had a cardiac arrest and we were going to give them a defibrillator, an implanted defibrillator, we actually had to crack their chest open heart surgery, and sew 2 patches to their heart, and then close up the chest and test the device. And that operation was associated with about a 5 to 10% death rate. So in the early 1990s, Medtronic, which is located in Minneapolis, and at the time Cardiac Pacemaker Inc., which is now part of Boston Scientific, were both developing these so-called transvenous leads, similar to pacemaker leads, but they had big coils on them that we could use to serve as the patches. And we were assessing this for the very first time at the University of Minnesota in patients who had had a previous cardiac arrest. And my job as the electrophysiologist was to induce ventricular fibrillation and then make sure we could get rid of the ventricular fibrillation. And I was working collaboratively with a heart surgeon who would help place the lead. Of course, we do that now as electrophysiologists, and the heart surgeon's not involved. But at the time, we were doing this in the operating room under general anesthesia. And the protocol that the FDA made Medtronic use involved inducing ventricular fibrillation, stopping it with this new device, 5 minutes later, inducing ventricular fibrillation again, but using a lower amount of energy. So if the device was capable of delivering a maximum of 30 joules, the second time we induced ventricular fibrillation, we had to rescue the patient with 20 joules. And then if that worked, 10 joules. And I performed CPR on that patient, and we were able to get the patient safely out of the operating room. And after I wiped the sweat off my brow and stepped back, I thought, well, this would be a really interesting model to compare the physiology of standard CPR to active compression-decompression CPR with a suction cuff device. So we got permission from the Institutional Review Board. We got consent from the patients. And when we induced ventricular fibrillation and had to use the lowest form of energy, which always resulted in a failed shock, we could perform CPR for about 10 to 15 seconds as the defibrillator recharged to get the patient out of BF. And so we started measuring the physiology, and we measured airway pressure, and we measured intrathoracic pressure with an esophageal manometer. That's a pressure measuring device in the esophagus. And we measured the amount of air moving in and out of the lungs, so-called minute ventilation. And we measured blood pressure in the artery and the veins. And we noted that the blood pressure went up about 20%, and the coronary perfusion pressure went up about 25%, and the amount of air rushing in and out of the lungs with each compression-decompression phase went up fourfold, as I mentioned earlier, to about 16 liters a minute with a suction cuff device. But we did not see any change in intrathoracic pressure in the esophagus, and that was bothering me. And so I started asking colleagues, why did they think we did not see a change in intrathoracic pressure? So Mike Sweeney is a pediatric anesthesiologist and intensivist. He trained in Philadelphia. And when I asked him what his thoughts were, years later he told me that he saw pressure curves, venous pressure curves in his mind from the physiology text of Guyton. And there it's very clear that changes in intrathoracic pressure result in changes in venous pressure in the right heart. And so he thought maybe he would try to simulate that by putting his thumb over the endotracheal tube so that we could block the air from rushing into the lungs.
Fantastic.
And it was literally one of these aha moments when we saw that pressure go down, that we realized we could affect blood flow in humans, in the operating room, and in pigs. And then we realized that the downside of using a PEEP valve is every time you squeeze a resuscitator bag, you feel the resistance of that PEEP valve. So we created the ITD or rescue pod. So when you squeeze down, there's minimal resistance to
air rushing into the lungs so the person doing CPR can feel resistance with their hands, and there's minimal resistance to air flowing out of the lungs with the ITD. There's only resistance if there's a vacuum created inside the thorax, and that closes off the ITD until a certain cracking pressure within the ITD, about a 10 or 16 centimeters of water, which to rush into the lungs. So we went from the thumb to PEEP valve to a more complicated valve that does what the thumb did, but only during the recoil phase when you allow the chest to passively or actively get pulled upward, and otherwise it is open.
Now, getting back to the Rock Pri-Med trial and the post-hoc analysis, just to run through the numbers so the audience is aware, the original Rock Pri-Med trial enrolled 8,700 patients. And of those 8,700 patients, there were about 6,199 that had data on quality of CPR. And you had mentioned the inclusion criteria for high-quality CPR, and it was relatively lax. In fact, the AAHA guidelines for 2015 have a higher recommended requirement for chest compression fractions of at least 60%, but goals of upwards of 80%. But of those 6,200 patients that had data, only 27% of that entire cohort had high-quality CPR, which is just a staggering number, especially when you take a snapshot over the country and look at the disparity in cardiac arrest outcomes and pre-hospital management.
That's correct. So of the 8,700 patients in the Rock Prime study, less than half of them had the correct rate and the correct depth. And and Dr. Yiannopoulos and others were being very loose with the definition of correct. So a range from 80 compressions to 120, and a range in terms of rate and per minute, and 4 to 6 centimeters in depth. If you tighten that up and go from 90 to 110 per minute for rate, and focus on 5 centimeters plus or minus 10% for depth, that fraction was even smaller. And so the reason I think that study is so important is because it demonstrated with or without the ITD that if you don't do high quality CPR, your outcomes go down substantially. And while it seems obvious, it leads us all to conclude that we have to figure out a way to both monitor the quality of CPR and focus on the quality of CPR. And it's not as though the first responders and people doing CPR aren't trying to do high-quality CPR. It's that it's actually very difficult to do high-quality CPR in the heat of the moment, especially if there's somebody young who is gasping and potentially moving, and you're trying to get them to a place where you can do CPR efficiently, and your adrenaline level is pumping. You may not be able to do high-quality CPR without some sort of devices to guide you. And in fact, when we discovered the fact that people are hyperventilating patients at 37 times a minute in our first Milwaukee study that I alluded to earlier, we told the manufacturer of the ITD, hold off on what you were going to do, which is put a little metronome on the ITD at a rate of 100 per minute for the compression rate, and instead we had the light flashing at 10 per minute for the ventilation rate. Years later, with the Rock Prime study, we realized that people were excessively or inadequately compressing the patient at the right rate and depth, so it became clear we need to give the people who are doing CPR better tools so that they know what 100 per minute is. Unfortunately, the AAHA came out with a recommendation 100 to 120, and in fact, 120 is too fast.
Too fast.
And the physiology doesn't support it, and the reanalysis of the Rock Prime study doesn't support it. The correct rate is about 105 to 110, as I mentioned earlier.
Sweet spot.
But the sweet spot. But the fact is, we're all very human. And I'll tell you a funny story to bring this to home. When we were in Milwaukee doing our first evaluation of the ITD, we first discovered that people were getting hyperventilated. That wasn't good because the ITD wasn't going to work if there was never a vacuum inside the thorax. But when we were trying to measure the vacuum inside the thorax in patients getting CPR with a little airway transducer, we often did not see the vacuum. And looking very carefully at a patient one day getting CPR by the firefighters, it was clear that this firefighter was leaning on the chest. It wasn't totally obvious. We were looking at his hands and the position of his hands on the chest, and we were looking at the pressure transducer, and it was always positive when he pushed down on the chest. We never had a vacuum. So after several different firefighters tried, I asked Dr. Perillo if I could also try. And the way I perform CPR with my hands is I always push down with my palm, but allow my palm to always completely come off the chest. And sure enough, we saw a beautiful vacuum with each recoil. And we went back to the fire station to look at the difference between the firefighter CPR and my CPR in terms of the vacuum inside the thorax. So we had a much greater vacuum with my CPR. The only problem was I was compressing the chest at 140 plus times a minute. So in the heat of the moment, I too, like all of us who are human, had my adrenaline pumping, and I had completely the wrong rate. So while there are no definitive studies to show that CPR prompting devices, and all of the companies and many people use them now to provide high-quality CPR, have resulted in improved neurologically sound survival, we know from the Rock Prime study that if you don't do high-quality CPR at the right rate and the right depth, you're going to hurt patients rather than help them. And if you do high-quality CPR, then you have a motor that is working relatively efficiently. And then I like to say you can add the turbocharger, which is the ITD, to further enhance circulation to improve outcomes. So high-quality CPR is the fundamental starting block. It's the foundation of trying to improve outcomes. But it's hard to perform high-quality CPR in the heat of the moment in the setting of cardiac arrest without tools, which is why I personally like automated CPR devices and feedback tools, if you don't have them, to guide rescuers on how to do high-quality CPR.
Beautiful summation, sir. Thank you for that. We want to be respectful of your time. I know you have a busy day ahead of you. I'm wondering if you could just briefly describe the SNAPPy CPR study, the role of sodium nitroprusside, stutter CPR, as well as the use of adenosine, which is pre-hospitally certainly we used for arrhythmias, as well as heads-up CPR, and the future that these modalities and techniques will hold for us.
Okay, well, I'll try to be brief. So SNAPPy CPR is sodium nitroprusside enhanced CPR. Stutter CPR is the use of intentional pauses at the very beginning of CPR. And adenosine, we know, is a drug that can stop supraventricular tachycardia, or SVT, and it also enhances circulation to the heart. And then you also wanted me to talk about other methods of CPR, including this concept of heads-up CPR. But in order to lay the foundation for all of those, we've got to go back and talk very briefly about the combination of ACD CPR and the ITD.
Yeah.
That combination was ultimately studied in another large NIH-funded study called the Rescue Trial in 7 U.S. sites with a total of 5,000 valuable patients, and 2,470 patients actually were randomized between a pair of hands or this device combination of active compression-decompression CPR plus the ITD. And over the 4-year period of time, those patients were evaluated primarily to say who survived the hospital discharge with good neurologic function. And that study was performed by a company which I founded, so conflict of interest, because nobody else wanted to take these technologies to the marketplace. And with this NIH-funded trial, with Dr. Al-Trahidi as the principal investigator, with oversight from the FDA and the NIH and the institutional review boards and the clinical events committee and the data safety monitoring board, those investigators found that 50% more patients survive, relatively speaking, with a device combination than a pair of hands to hospital discharge. So that was an absolute 3% improvement in neurologically sound survival. And at the end of a year, 49% more patients were alive with this device combination group. And ultimately, in March of last year, the FDA approved this device combination as the first device ever to improve the likelihood of survival after cardiac arrest in the United States. So we were very pleased with ultimately that final outcome. And that technology is starting to be used now in patients across the country, which is very gratifying. Along the way, it became clear that if we could have this high level of circulation to the heart and the brain, that we might be able to use drugs and approaches that heretofore we would not even think about. And so one of my colleagues, Dr. Yiannopoulos, started to use sodium nitroprusside, which is a very, very potent vasodilator. As potent as adrenaline is in constricting the arteries, this is in the opposite way through nitric oxide, a drug that opens up the arteries and improves circulation to microcirculation to the heart and the brain. He used that in combination with active compression-decompression CPR and the ITD, and he showed a striking improvement in outcomes both in pigs in cardiac arrest, in pigs with a heart attack, STEMI pigs, and then more recently in patients in cardiac arrest in his cath lab. And so I believe that the combination of these mechanical devices to enhance circulation plus sodium nitroprusside in some patients who are refractory to traditional therapies like shock therapies may benefit from sodium nitroprusside. I don't want you to run out and start using that. It needs to be done only with active compression-decompression CPR and the ITD and in a controlled manner. But we use sodium nitroprusside all the time in the cath lab to vasodilate coronaries, and that's what we, led by Dr. Yiannopoulos, have shown in animals and in humans. And then Dr. Yiannopoulos went on, and I think it's a very significant advance, to demonstrate another physiologic problem in CPR, which is that if you get to a patient really late and you start to give them good circulation, that the reperfusion of the heart and the brain after being down for a long time can cause injury. And the analogy I like to use very briefly is if you are transplanting a kidney and you fly it from Chicago to Minneapolis to transplant it, you just don't put it in and open up the aorta and have blood flow immediately go to the kidney. You trickle the blood in, let the kidney warm up, and you let the kidney get used to this enhanced and new blood flow it hasn't had for several hours. If you have a patient who's been down for 10 to 15 minutes and you start pumping blood into the heart and the brain, you can get reperfusion injury. And that physiology has been worked out well, and the biochemistry has been pretty well understood for patients with STEMI and stroke. So Dr. Yiannopoulos has been using the concept of 3 intentional pauses, 20 seconds each, during the beginning of CPR to prevent reperfusion injury. And we've only shown this in pigs. But as we've looked at this concept of intentional 3 20-second pauses, we've realized that maybe one of the benefits of delivering 30 compressions and 2 ventilations during BLS is, in fact, that we provide some reperfusion injury protection analogous to this stutter CPR. So, and there was a very large study also performed by the Resuscitation Outcomes Consortium of the ROC study published last year, which compared 30 to 2 versus continuous chest compressions. And indeed, they found a 10% improvement with 30 to 2 versus continuous chest compressions in the overall patient population for better neurologically sound survival. And if they looked at the patients who actually got what they thought they were supposed to get, so-called per protocol analysis, where they knew for sure people got 30 to 2, and they knew for sure people just got continuous chest compressions, there was an absolute, undeniable benefit of 30 to 2. And I think one of the potential reasons for that has to do with this reperfusion injury protection. And the other has to do with the fact that it's hard to do continuous chest compressions. You get tired, and the pause allows you to do better quality CPR, and the 2 breaths allows you to inflate the lungs. And if you inflate the lungs, and you also provide an opening for the arteries and veins so you can better circulate blood from the right to the left side of the heart. So we haven't talked about 30 to 2 versus continuous chest compressions, but it's all interrelated. And 30 to 2 may provide a similar benefit to stutter CPR. Mm-hmm. Finally, head-up CPR. Heads-up CPR is something that we've been studying for the last 2 years. And for me personally, it's probably the biggest breakthrough that I think we have had, although it's still early in our understanding of the physiology of CPR. For over a half a century, we've pushed on a patient's chest when the patient's lying flat. That results in an increase in arterial blood pressure to the brain, but it also simultaneously results in an increase in venous blood pressure to the brain. So you have a pressure wave that goes up on the left side on the arteries to the brain, and a pressure wave that goes up on the right side via the veins to the brain, and you squish the poor little brain in between these 2 pressure waveforms. And I like to say we are creating a concussion with every compression. And we discovered, quite by chance, in collaboration with a Korean group, that if you put the head down and the feet up, which is what they wanted to do to get people into elevators in Korea during CPR, because the elevators are small, so if you put the feet up, you could get a stretcher into the elevator. We discovered that if you do that, intracranial pressure goes sky high, and the cerebral perfusion pressure is terrible. We did this in pigs. And then when you put the head up and the feet down in pigs, intracranial pressure drops, and the pigs started to gasp, and cerebral perfusion pressures were markedly higher. And so for the last couple of years, an international group of collaborators has been looking at the physiology of head-up CPR. If you put the head up, you have to pump blood uphill, which means you need a more efficient pumping system, which means you need the impedance threshold device concept in the mix. But when you do that, at least in pigs, we profoundly improve blood flow as well as cerebral perfusion pressure. We shift the distribution of blood in the lungs and in the heart during CPR. And it's my belief that at some point in time, it may just be a pillow, it might be a wedge, or it might be a device, but elevation of the head during CPR with the impedance threshold device and or some sort of automated CPR device will ultimately be the position that we perform CPR in 20 years hence.
Fascinating, and I think we're certainly looking forward to see the results of those ongoing studies. Now, if you would allow us just a few final questions to wrap up our show. You are a cardiologist by training, and a large portion of your research is in cardiac arrest and outcomes and interventions. What would you say, or what is your advice or recommendations in regards to primary prevention? I guess what I'm referring to is the prevention of atherosclerosis, looking around the United States of America, the obesity epidemic, poor nutrition, poor diet, lack of exercise, sedentary lifestyle. What do you say to folks regarding primary prevention?
I think as a physician or as a healthcare provider, primary prevention is fundamental. So we start with diet. We start with stress levels. We all should be exercising, whether it's just walking or running or swimming. And we are in the middle of a terrible epidemic of obesity. And if you combine obesity with smoking or obesity with diabetes and smoking, that is a setup for absolute disaster. And so absolutely we need to focus on trying to an ounce of prevention goes a long ways. Now, there are some people who are born with genetic abnormalities and they can be fit as a fiddle and have a cardiac arrest. But most people who have a cardiac arrest have a cardiac arrest because they haven't taken care of themselves. And they've smoked, or they're morbidly obese, or unfortunately they develop diabetes, again, often because of lifestyle issues. So eating a healthy diet, exercising regularly, reducing stress levels, not smoking will go a very long ways towards preventing cardiac arrest and reducing the death rate from this still leading cause of death in the United States and in developed countries.
Fantastic. Thank you for that, sir. If you were to travel back in time and you could give any piece of advice to your 30-year-old self, what words of wisdom do you think you would impart?
So I think that I have always been a relatively curious person, but I think that the 30-year-old self, my words of wisdom were to probably challenge the norm, especially if the norm is not working. And if we just think about cardiac arrest space, if most people still die, we still have in New York City a 85% mortality rate of cardiac arrest, all rhythms, all causes. And if you look at what I knew when I was 30 and I'm now 60, most of the things we took for granted are not true. Start with, we think we understand compression rate and depth. We didn't. We thought we understood the physiology well. We didn't. We thought that giving a breath was going to be life-saving, but it could be deadly. We thought that adrenaline would be life-saving, but it could be deadly. We thought that the position of the patient should be flat, but it shouldn't be probably. So I would say that if you're curious and you want to try to improve outcomes, challenge the norm and make sure that it makes sense physiologically or makes sense logically. Forget the physiologically, just logically. And so when we go about our activities, whether we're electrophysiologists or whether we're sitting in a desk and watch somebody go down, challenging the norm to change outcomes, I think, is important if you want to become a scientist.
And then the last question, sir, this is going to be released during EMS week, and our hope is certainly that it helps to portray the physiology of cardiac arrest and sparks that curiosity in providers to learn more. Do you have any asks or requests of the EMSNation audience, and where can folks learn more about the rescue CPR system in general?
So I think the biggest ask that I have is to ask people not to give up. If you're performing high-quality CPR, as we've talked about it today, or you're going to learn about it once again during EMS week, recognize that what you learned as a student has already changed and it will continue to change. And we're all in search of the truth, as it were, to optimize outcomes after cardiac arrest. But what people do all too often is they give up. And it's not just the EMS community, it's the doctors and nurses in the ED, it's the doctors and nurses in the cath lab, it's the doctors and nurses in the operating room when they say, oh, there's nothing more we can do. It's the doctors and nurses who are taking care of a patient who hasn't woken up 5 days after cardiac arrest and cooling. They were pulling the plug too early on patients who were not allowed to wake up a week after cardiac arrest. And we discovered this, 25% more patients will be alive if they let them wake up after several days. The same thing is true in the field. If you only perform CPR for 15 minutes, you're depriving some patients the chance for another life. So don't give up.
Powerful words, Dr. Lurie. Thank you so much for your time.
Faizan, thank you so much for this opportunity. In terms of finding out more about rescue CPR or ACD plus ITD CPR, there are two sources. One you referenced already, which is an article that was published in Anesthesia and Analgesia this year. It's a CPR review article, and I'm the first author. And the second is the website of the company that now sells and distributes the rescue CPR technology, and that's Zoll Medical.
Amazing. Thank you so much, sir.
Thank you so much. Take care and have a great day, everybody.
That was a fascinating conversation with Dr. Keith Lurie. I think it is profoundly helpful to really dig in and understand the physiology of our CPR patients, how important the quality of CPR is, and challenging ourselves to really uphold ourselves to the highest standard and metrics, have active feedback when we respond to out-of-hospital cardiac arrest, and to implement systems of care and the chain of survival to improve patient outcomes in our neighborhoods, communities, on the statewide level, and to really help flatten or iron out the disparities which are beginning to creep up in regards to our patient outcomes. And we certainly applaud those who are incredibly high performers, who follow the Resuscitation Academy mantra of measure and improve. And we encourage those who are eager to embark on the same path to remain resilient, find the best practice evidence-based medicine that you can, and start initiating those changes in systems and education onto the why we respond to CPR the way we do within your service. This is going to be a great EMS week for us, so please do subscribe to the EMSNation podcast on iTunes. Tell other folks as they enjoy EMS week to log on to Facebook, www.facebook.com/prehospitalnation. EMSNation, thank you so much for listening to the podcast, and thank you so much for dedicating yourself on a daily basis to go out there and provide incredibly high quality pre-hospital care, and to committing to be on a path of both personal improvement as well as systems-based performance enhancement. Now, we'd like to remind you we could really use your support. If you happen to have an Apple Watch, we'd love it for you to download the Perfect CPR app and use it during training, and let us know what feedback you have. At present, it's designed to give audio as well as haptic feedback during training cardiac arrest scenarios, and our hope is this can help improve outcomes both in the community and on a systems-wide basis to help decrease the disparity in outcomes in out-of-hospital cardiac arrest. Please tune in for the next episode of EMS Nation during EMS Week. This is Faizan Arshad, wishing everyone a safe tour.